It's my pleasure to announce or to present today two gentlemen that also have been friends of our chapter, Tom Rennell and Ryan Westrom from Colorado Hospital Association. They are going to be our closing speakers. And everyone is always waiting for the two of you to close out our conference. They love to hear from you. So Ryan is the Director of Finance for Colorado Hospital Association. He has over 15 years of healthcare experience with a focus on hospital finance, payment reform, and hospital reimbursement. He's also a member of our board. Prior to joining CHA, Ryan worked in finance and reimbursement at a Colorado hospital as well, and for Medicare fiscal intermediary in Colorado. He currently sits on our board, our HFMA board, and the Colorado Hospital Accessibility and Sustainability Enterprise, better known as CHASE board. That is just a mouthful. All right, now Tom is the Senior Vice President of Financial Policy and Data Analytics for Colorado Hospital Association, where he is responsible for the development of the association's position on issues involving finance of healthcare services and provides leadership and direction in the development of CHA Healthcare Analytics Program. Tom has more than 20 years of experience in financial management, in financial management in healthcare. Before joining the association, he worked for Kaiser Permanente of Colorado, where he held roles in the leadership of financial planning and analytics, revenue cycle, Medicare and Medicare reimbursement. So I think I'm all talked out, which is a shocker for me. I am now going to turn it over to Ryan and Tom. And again, thank you, gentlemen, for the time today, and we look forward to your presentation.
Well, hello, Pilar. Thank you so much for the great introduction. Just testing the audio. How am I sounding? Thumbs up. Thank you. Well, good afternoon, everyone. Thanks for having us here for the HFMA Spring Symposium. It's been a great event the last couple of days, and my hats off to the board, all the volunteers, the sponsors. It's a big effort to put this on, and it was definitely done differently, and really appreciated it. Today, we're going to provide a brief overview of the hospital industry here in Colorado. We're going to explain how COVID has impacted the industry, and then we're going to try to put that into the context of the current legislative session. Lots going on in that environment. Ryan is also going to discuss the status of some past legislation and how that's impacting hospitals. We're going to try to move along here pretty quickly, and we'll try to keep it focused and have some time for questions at the end. I think Jessica's moving the slides. If you could go ahead to the next one, Jessica. Oh, thank you. We're not going to spend any time on CHA, but we are the Colorado Hospital. Provide as much support as we can for all the hospitals here in Colorado. You can go to the next slide, Jessica. We've all been living through this global pandemic, and most of us are really tired of hearing about it, but yet it really hasn't gone away. You can go ahead and go to the next slide, Jessica. You know, hospitals are providing care to COVID patients and non-COVID patients. Hospitals are administering vaccines. Hospitals are dealing with fluctuating, patient volumes and declined revenue base. Hospitals are trying to maintain staffing levels and morale, necessary protective equipment. It's been a significant and impactful year, as you can imagine. We can go ahead and go to the next slide. So volumes, patient volumes are down. These charts in the next couple of pages represent year-over-year changes during the past 12 months. And on the inpatient side, on the left is discharges, and they've been fluctuating, but in no month over the past 12 months have we returned back to 2019 or prior year levels. Now, length of stay is up, and in some cases significantly up. You can see that on the top right. The moral of the story here is that the mix of patients and services has been changing significantly. It continues to change and it continues to evolve. And we do expect that to continue here, throughout 2021. We can go to the next page, Jessica. Outpatient, massive decrease in outpatient services at the onset of COVID, largely due to the suspension of all non-emergency outpatient procedures. And they've rebounded back to prior year, 2019 and early 2020 levels. But again, the mix of services is changing significantly. You can see on the right that ED visits and ambulatory surgery visits continue to stay in decline, upwards of over double digits for every single month. So quite a bit of change in the mix of services on outpatient as well that we've been seeing. We can go ahead and go to the next slide. So as you begin to put together this, change in the mix of services, the lower utilization that we've been seeing, hospitals are also experiencing some significant payer mix changes. Now that came up in a session, I think that you heard earlier this week. Medicaid and uninsured patients are increasing significantly, and that is expected to continue throughout this year. As well as continued decrease in travel, as well as continued impacts from the economy. It just leads to some pretty massive impact and pressure on hospital revenues. Hospitals in 2020 experienced a near $1 billion decline in revenue, upwards of another $1 to $3 billion in 2021, depending on how all this evolves. And that represents about 10% of revenue, top line revenue in each of those years. So that's a 10% revenue hit for 2 years running. It's pretty significant. We can go to the next slide, Jessica. The feds are helping, so this is good. In Colorado, hospitals have received over $1 billion in federal provider relief funds. Those have also been discussed at one of the HFMA sessions here this week, as hospitals are trying to, square away and validate the revenue that they received against, revenue or expense changes. And it's uncertain whether hospitals are actually going to be able to keep all of these funds. But to date, it's been over $1 billion. And then we can go to the next slide, which is whether you can get that out of this chart or not. The federal funds have been more targeted towards rural hospitals, at least proportionally wise, maybe not dollar wise, but and that's good news. Over half of the hospitals, half of the rural hospitals here in Colorado had a negative operating margin prior to COVID. So half of our rural hospitals in Colorado had a negative operating margin pre-COVID. 70%, over 70% of the critical access hospitals here in Colorado had a negative operating margin pre-COVID. COVID certainly has put more pressure and exacerbated that. The federal support has helped. We have not had a hospital, at least in my recent view, that has gone out of business, and we are hoping to keep that for sure. So there's the context, there's the background of what's been going on in the industry. Certainly a lot of financial pressures, as well as just all the other operating implications that hospitals have to deal with. And so now we'll try to put that in context of the legislative session. The next few pages are just some bullets that I typed in here. I don't have any fancy pictures at this point. It is all evolving quite a bit. And we'll speak a little bit more about that here in a minute. But in case you don't know, the start of session was delayed over a month. So it typically starts right in the beginning of January, and we started in mid-February this year, which has pushed everything back. The legislative session typically ends on or near May 1st, right, the beginning of May. Now we'll extend through the end of May, possibly into early June, and they're reserving some time to come back in the summer as well. So not sure how much everyone on the presentation today monitors legislation activity. There's a lot of it that's going on, and it's across all industries. You know, we're going to talk about healthcare today, but clearly the legislative proposals are across all industries. You've probably heard about some of those, but there's quite a bit that is going on in the legislative session right now. We're a Democratic Party dominated state here in Colorado, and that matters. There is ability to pass what the Democrats would deem to be progressive policies. For healthcare, the focus continues to be on affordability and a sub-focus on hospitals and pharmaceuticals. Of course, COVID response will continue to be a real important and necessary priority. Currently, we at CHA are monitoring over 85 bills that have impact to hospitals. So a lot of activity. That isn't unusual at this point in the year, but it is a lot of legislative activity. Let's go ahead and go to the next slide. You know, the highest priority is House Bill 1232. It's called, what it's called is the Standardized Health Benefit Plan Colorado option. We'll talk more about the details of it in a minute. But if the Democratic Party and the administration are behind this legislation, which they are, you know, they certainly have the political majority to get it through. You can see the charts there. Again, we are dominated by Democrats and the administration, and Governor Polis is Democrat as well. Governor Polis referenced the Colorado option in his state address this year. And another thing about this legislation, it's also being presented as an equity issue. We'll talk a little bit more about that in a minute. We can go ahead and go to the next slide. So you can, what is public option? You can call it kind of whatever you want, really. But I'm going to try to explain some of the points of it here. So what the promise is to improve prices. These are insurance prices for individual and small group insurance market, which is comes under the authority of the ACA. This does not include large group. The promise is to improve prices by 18%, phased in over 3 years. It also requires a new standardized plan. And that standardized plan has less out-of-pocket costs for enrollees, has better benefits and more first dollar coverage. It includes an expectation to improve access and affordability for those in rural and those who have historically had barriers to getting healthcare, people of color, immigrants, and low-income individuals. Now, the PowerPoint has on the bottom that a quasi-government entity may kick in. That's actually been already stricken from the legislation, so that actually isn't the case. But those are important goals, right? Improving price of insurance for small group and individuals, people who purchase individual coverage on the ACA, and having in removing barriers is something we can all rally behind, for sure. I mean, the challenge is, how do we get there, right? How do we improve access and affordability to the more vulnerable and those facing barriers? And, you know, this legislation does not get us there. It's nearly the same as last year's attempt at a public option. That was not passed. COVID kicked in and they put it on the side. But there's just a little bit more color and makeup on it this year. So one of the important premises that has been proposed this year, and this is different than last year, is that it starts with allowing the market to get there. If the market, that being insurance companies and providers that they work with, if they can achieve this 18% reduction, then there is no more legislation that will kick in. But if they can't achieve that, and there are no ways suggested on how they achieve that, it would default to mandated rate schedules on providers. You could say price controls. You can use whatever words you want, but it basically will set the prices for providers, hospitals, physicians, potentially pharmacy if they can get to that, and potentially all providers. It requires insurers to offer this subsidized, standardized, enriched plan to compete on the small group and individual market alongside insurers that are already offering those products. So it's a subsidized product that would be offered on the exact same platform as the current small group and individual products from the same insurers that are out there today, Anthem, Kaiser, United. It's just that this product would be subsidized through lower payment rates put on to providers. Now, there's a lot of issues and detailed and in the weeds, and actually some of those matter significantly. Some are broader and really systematic. And it continues to change. Just yesterday, there was new strike below language that was put forth. We continue to work with all of our stakeholders, the insurers, physicians, other providers, and provide feedback to the sponsors suggesting changes. But some of our most fundamental challenges are that it's just not good policy to achieve the goals that they're setting out to do. The 18% reduction was originally a 20% reduction, but I think either they didn't like the round number or it wasn't divisible by a 3-year phase-in, and so now it's 18%, but it's arbitrary. There is no basis for why premiums need to increase 18%. In fact, Colorado already has the 6th lowest payment rates for individual plans in the country. And why is that? That is because last year reinsurance legislation was passed so that insurers didn't have to cover the cost of high cost cases. So we've already made progress in this vein. And as I said, Colorado is already the 6th lowest payments insurance rates in the country. It also is based on these mandated fee schedules to pay providers. And obviously setting payment rates is not competitive. Price controls are not competitive. You know, I was thinking of an example today. Let's say that hotel rates in downtown Denver are too high. We all decided that they were too high. And so following this plan, we would pass legislation that would cut the payments to all the suppliers of the hotels and the workers by 20%, so that then hotels could charge less. And I know that sounds really goofy, right? The workers would leave, or the suppliers may go out of business or leave. But in a sense, that's what's happening here. It's forced cutting of rates to achieve lower insurance premiums. The payment formula, which they've announced for hospitals, they haven't announced it yet for physicians or any other providers on how their payments would be modified, but they did use the same formula that they had last year for hospitals, so we already know what that is. It isn't, it's politically based and it's not evidence-backed. Just a ridiculous example is that if a hospital is part of a health system, they would receive a 40% less reimbursement under this plan. That has no basis. It's just that the administration is not fond of hospitals that are in health systems, or maybe it's because those hospitals have more commercial coverage that they can cost shift their business onto. And finally, really, all of the legislation, if you read through it, there's no discussion about how to improve care, really how to improve access. There's nothing that is being put forth in this legislation that would lower the real cost utilization of healthcare. It's just setting prices to providers. And what ends up happening is it subsidizes the small group and the individual market. And that isn't necessarily a bad thing, but what it does mean is that everyone else who aren't on those plans is going to end up paying more for it. I think that's where I'm going to kind of leave things. I think there's one more slide, Jessica. It's just a chart that shows there we are in Colorado. This is the individual insurance market compared to every state in the country. It shows how low our premiums currently are, which I had mentioned previously. With that, I thank you. We will have some time for questions or comments as we get to the end. I'm going to turn it over to Ryan, who's going to take us through some of the impacts of past legislation. Thank you much.
All right, thank you, Tom, and good afternoon, everyone. Jessica, if we go to the next slide, please. So today in my part of the presentation, I'm going to talk about some of the Medicaid legislation and Medicaid programs that are already underway. Particularly, I'm going to talk about the CHASE program, or the Hospital Provider Fee Program. I'm going to talk about the Hospital Transformation Program, or HTP, and kind of the upcoming timelines. So we'll touch on that briefly to take a look at some of the upcoming requirements that hospitals will be working on. And then we're going to talk about 3 reports that the state released in January of 2021. And these reports are required by legislation, and they are sent to the Colorado legislation. And a lot of the numbers and things you're hearing publicly are coming from these, particularly around hospital finances and community benefits. So we're going to talk about the Hospital Transparency Report, community benefits, and the 2021 CHASE report. So we're going to take a look at some of the trends we've seen in past years, and then really focus on some of the trends and changes we're seeing, particularly moving from 18 to 19. So we're obviously talking about pre-COVID numbers, but really starting to see a change in some of those trends. So as I mentioned, we're going to start with the CHASE report, of the Hospital Provider Fee Program. And so this is a slide that I probably presented over the last few years that most of you have probably seen if you've participated. So this is a 3-year comparison of the hospital provider fee, starting in 18-19 in the left column, all the way to the proposed 2021 CHASE model that will be presented to the CHASE board on Tuesday, April 27th. So what we have here are the fees and supplemental payments that hospitals see on an annual basis. And we'll start in that right-hand column, the proposed 2021, and we'll start at the very top. On the top, we have the fees in red, and at the bottom, we'll have the payments and net gain in black. So if we start on the very top, we have labeled there fees for payments. You'll see that in the proposed model, about $600 million will be assessed on the hospitals to be matched by the federal government. So that's about a $23 million increase from the previous year. So what that means is there's $23 million of additional fees being assessed on the hospitals that will be matched by the federal government, that will come back in payments to hospitals. So that's a good thing. The more that number goes up, the higher the payments back to hospitals are. If you look at the next line down, which we have labeled as expansion, so the provider fee covers Medicaid expansion in Colorado. And we're talking Medicaid expansion both pre-ACA, so we had some pre-ACA Medicaid expansion that the provider fee actually started in 2009. And then in 2014, when the state implemented Medicaid expansion per the ACA, or the federal ACA legislation, the provider fee was set up to cover the state share of that. So in the early years, you may remember that there was 0% state share. And we did see the net gains increase dramatically at that point. And then we're gradually increasing to 10%. So the 2021 year is the first year that Medicaid expansion is at 10%. So what you'll see here is in the current year, the proposed model, based off of the state's estimates, the provider fee and the hospitals will be assessed $373 million to cover those Medicaid expansions. Now, if you compare that to the previous year, just to the left, it's about a $100 million increase in fees assessed on hospitals. So we're going from 275.6 million to 373.2 million. So we're talking significant increases. Now, I mentioned this is the first year of 10% state share. So that's a piece of it. But the vast majority of that $100 million increase is related to the Medicaid enrollment. So what we saw, obviously, when COVID started in the spring, was an increase in unemployment, and that kind of correlated to an increase in Medicaid expansion. But what was also happened in the spring were the CARES legislations that the federal government passed. It made payments to individual taxpayers, those payments to businesses, small businesses, those sorts of things. What was also included in that legislation was a requirement that state Medicaid departments could not disenroll Medicaid clients until the federal emergency was exhausted. So in the beginning of last year, we didn't have that, obviously. We saw a slight increase last year because of that, but this year, because the federal emergency has been expanded till November, the state needs to include in their estimates about 200,000 additional Medicaid enrollees that cannot be disenrolled. So typically on a monthly basis, we'll see people signing up, but we'll also see a churn off. So there'll be some offsets and some ebb and flows, but right now it's just going up because the Medicaid department does not have the ability to disenroll those Medicaid clients. So a lot of that is due to that. A lot of that $100 million is due to that not being able to disenroll. So what that $100 million increase represents is $100 million of fees that cannot be matched by the federal government to come back through payments. Obviously, after November, if that goes away, in next year's model, we're hoping to see something similar to 18-19 numbers, but obviously that's a ways away and we'll see what happens. But I think as we're all seeing the vaccinations and kind of the trends going, we're hoping that is true. Then if you go down, you'll see the administration fees that are assessed on hospitals increased about $4 million. You know, there's typically a $2-3 million increase from year to year for those expansion costs, or those administration costs, I mean. Then on the next line down, statutory general fund transfer. So you'll see there's a $62.7 million fee for that. What that is that represents covering last year's state budget deficit. So in last year's budget, there was a $2 or $3 billion deficit, and all the state programs went back and we're trying to find money. And last year's model, they took $114 million of fee, and that was directly transferred to the state budget to offset that budget deficit. In the current year, it dropped about $67 million. So coming into this year, we thought, we'll see an increase in fees, but obviously that $67 million decrease was more than offset by that increase in the Medicaid expansion. So that brings us to the total fees that are being assessed. You'll see it just over $1 billion last year. That increased to $1.72 billion this year. So about a $60 million increase in fees being assessed. So that's the fee side. That's what's being assessed on hospitals to fund the provider fee program and Medicaid expansion. The next line down, you'll see supplemental payments. Now we did see a larger increase in the supplemental payments. You see it going up about just over $75 million or so. So that translates to a slight increase in the net reimbursement gain from year to year from last year. So $392 million last year to $410 million. Now there is one thing I will say, that those payments do include the Rural Support Fund that's related to the Hospital Transformation Fund. So that's about $12 million that's being included in that net gain that's being specifically paid to, I believe it's 22 specific rural hospitals that HCPF identified to receive those funds. But regardless, a year of uncertainty, not knowing where revenue projections would end up this year, being equal to where we were in the 18-19 model was pretty good. An $18 million increase over last year. I think coming into this year, like I said, we had no idea where that was going to end up. So I view that as definitely a positive. And then two other things on the provider fee, and we talk about this every year, but it is important. There are two federal restraints that the provider fee has. And one is the percentage of upper payment limit, or the Medicaid payments in relation to cost. So the state can pay out up to 100% of Medicaid cost through base rate payments and supplemental payments. What you'll see here is we're at about 95.62%. Typically, we're in about the 97, 98% range. So we're down from that, down from last year, and about a 1.5% down from 2 years ago. So our Medicaid costs are rising, but those Medicaid payments are not keeping up with those cost increases. And on the next line down, you'll see why. Also, the second restriction is the NPR, the net patient revenue percentage. So each year, the state calculates the net patient revenue. They can assess up to 6% of NPR on hospitals. So as you'll see, the last 2 years, That's it. That's the limit. There's no more fees can be assessed. So they've gone up to the limit, and those are the payments that can, the fees that can be assessed to cover all of those different categories we talked about above. Expansion, administration, and payments being the bigger ones. But also the general fund transfers are included in there, and expansion expenditures. So really those two being included in this year's model really brought us up to that 6% and limited those payment increases that potentially we could have seen in this year. Jessica, if you go to the next slide. So related to the hospital provider fee or CHASE model is the hospital transformation program. And once again, this is a program I've been presenting on for years now, probably presenting here since 2016 or 17. Discussions between CHA and hospitals and the state go back to 2015, if you can believe that. So quite a ramp up and discussion period, but April 1st, the HTP program was, after many delays and discussions, and then more delays, was implemented. So April 1st, HTP was actually implemented this year. What that means is on April 1st, HCPF began accepting HTP applications from hospitals, with April 30th being the deadline for all participating hospitals to get their application into the state. So hospitals are going to submit that. The state's going to review it, or the state's vendor, Myers and Stauffer, will be reviewing it and giving questions and feedback to the hospitals, requests for additional information or RFIs, requesting additional explanations and what have you related to their application. With their ultimate goal being, and they've said this publicly, they said this to the CHASE board and at the MSB, their long-term goal is to have everybody participate in this program. They want everyone in this program because really, as you recall, the focus is based on outcomes and value, and they want to move to that. That's been a goal of the states for many years now, and that's the goal of this program. So they want all the hospitals to be in this program and participating. So they're going to be working with hospitals closely to make sure that they do everything they can to help the hospitals get there. So on a process standpoint, what that looks like is, regardless of when in April the application is submitted, the state's vendor will have 20 business days to review that application, at which time there will be a request for additional information sent to hospitals or an email or communication saying, all right, application's good, you're all set. If a hospital receives a request for additional information, that hospital will have 10 days to review the questions, submit any additional feedback or explanations or data or whatever was requested in that information. They'll have 10 days to turn that around to the state. So the goal being, by the end of May, all hospital applications will be accepted by the state. There's an additional review that has been set up by the CHASE board. They set up a subcommittee, the HTP Oversight Committee. So after the applications are accepted and approved by the state, they will go to this oversight committee, which is a committee of community groups that will participate in reviewing the scoring of the applications. Now, it's important to make the differentiation. HCPF is accepting the applications and scoring the applications by the hospitals, communicating with the hospitals directly. The HTP Oversight Committee will be scoring HCPF's scoring on how HCPF scored those applications, making sure they follow the purpose of the program, the outline of the program, and that everything meets what was required and what has been approved through the program. They're not approving the application. They're not sending questions or telling hospitals to do more. They are approving what HCPF has reviewed and that is acceptable along the HTP guidelines. So all communications from this subcommittee will go through HCPF, and the back and forth will happen there. With HCPF, as I've said publicly, they don't anticipate that there will be a need to make major changes to any application. Now, not saying there won't be something back to the hospital saying, okay, in your implementation plan, maybe address this. Anything major, anything that potentially they missed or there is a valid question or issue, that could go back to the hospitals, but that would go back to the hospitals from HCPF, not this group. So this group is kind of a one and done. They're going to review the application scoring, they're going to vote on it, and they're going to pass their recommendations on to the Chase board. So that will be happening in June of this year. So by the end of June, that whole application process should be complete, and this subcommittee will be presenting their findings to the Chase board in July of 2021. So, and then one more important thing to note is if there are any disagreements between the oversight committee about an application or how it was scored, and HCPF can't resolve that with the subcommittee, it doesn't go back to the subcommittee. That's gonna be elevated to the Chase board for final determination. So, like I said, this subcommittee is one and done. After the application process is complete, after June, that committee will sunset more or less. So July, we'll have all the applications presented to the Chase board and then published publicly. So anyone can go out and see those applications the hospitals have submitted for the HTP program. August begins the implementation process. So the application that will be submitted is more of a high level, what HTP is, what you're going to be working on, and that sort of thing. It's not a super long application, but it's more high level. The implementation process plan will be the more detailed specifics on what your hospital will be doing in this program. For example, your detailed timeline or your critical milestones that you're going to meet during the program. And then what are the responsibilities of your partners? Are you working with a community partner in something one of your measures? Are you working with someone outside of your hospital? What will be their responsibilities? So really getting into the detailed specifics of your measures and what's going to happen and detailing that out. That's what the implementation plan is. So those will be submitted in August with a back and forth with HCPF with the goal of having that, or the deadline of having that process completed by November 2021, which will allow 4 months for hospitals to get ready for HTP applications. So December through March 2022, they're calling a ramp up. Hospitals will have their plans finalized. They'll know what they're doing. So getting your software, your data, your resources in order to begin the HTP program. So HTP activity will begin April 2022 with that first reporting activity in July of 2022. So really a full year before HTP begins right now, but there's a lot of work to be done by the hospitals and a lot of things to meet and a lot of back and forth discussions with HCPF, I think. So all of these implementation application plans will be submitted through the HCPF's software, what they're calling CPAS application or CPAS software. It's all electronic and submitting through a web-based platform. So all of that information will be uploaded there. And that is also where hospitals, when we get into those outcome years, will be able to monitor their process and how they're doing in the program. So if we could go to the next slide, please, Jessica. So that's really the Medicaid payment reimbursement side. Now I wanted to focus a little more on those 3 reports that have been released recently, and a couple of them are new to Colorado. The first of which is the Hospital Financial Transparency Report. Now, these next slides, and like I mentioned earlier, we've heard a lot about hospital finances over the past few years, and some for valid reasons, some to run legislation, right? Like Tom mentioned, the public option. A lot of these discussions, especially publicly, are looking at really wide ranges of trends. And this report does exactly that. It's really looking at changes from 2014 to 2019, not getting into the detailed specifics of changes between years. And we'll talk a little bit more about that when we talk about the Chase report. But really, so what you'll see here, I think the one that really jumps off here is a 38% net, or 35.8% increase in net patient revenue growth. That's a big number. Over 6 years, you kind of can break it down annually, but what we saw prior to 2019, those trends were going up significantly. But 18 to 19, we did see that curve bend a little bit. And in some cases, and we'll talk about it more, going the other way, not mentioned in this report. So some of the things that hospitals have been working on, I would say hospitals have been working in these areas for years, but we're seeing some of those programs and benefits come to fruition, not identified here, not really identified publicly all of that much. So I think it's important to keep that into context. We also see uncompensated care costs have decreased. Now, the big reason for that obviously is we're using 2014. That's the first year of Medicaid expansion, ACA Medicaid expansion here in Colorado. So we would expect to see that as we move into a full Medicaid expansion year. Operating expenses had an annual growth of 5.2%. And then obviously same with uncompensated care decrease, payer mix shift to Medicare and Medicaid. As we're opening up Medicaid expansion, obviously we're going to have more enrollees. I think the latest number of Medicaid enrollees, including those that cannot be turned off, was over 1.4 million Coloradans are on Medicaid currently. So a significant portion, 25% of the population on Medicaid. One other point I want to mention for those hospitals out there who are familiar with the hospital transformation or the hospital financial transparency report is HCPF is currently holding stakeholder meetings with the goal of improving consistency of reporting, in particularly in the A&G cost submissions. What we saw is some big swings between large hospitals and small hospitals and systems in those percent of A&G costs, from under 6%, to over 30%. So a wide range. So really digging into that to make sure we're all including the same things when we're reporting. Obviously, from hospital to hospital, system to system, there are different cost allocations. So really want to dial in on that and make sure when we're using this information publicly, we're all on the same page. Next page, please, Jessica. So the next report is the community benefit report. So similar to the previous report, this is brought on by legislation and it is based off of self-reported data. So the previous report was audited financial statements, Medicare cost reports, specific data points. This is more related to community benefits and Hospital 990 nonprofit status reporting. So this is the first year of this report. So on this first trend, or on this first metric, we don't have a trend. So this is the first year that we analyzed specific community benefit for Colorado. As you see in the current year, it's at $525 million for Colorado. So just to put that in context, that $525 million is about 8.25% of hospital net patient revenue and about 7.8% of total revenue. So a pretty good chunk of what hospitals are receiving in revenue is going to community benefits. But how that compares to previous years, we don't know. So in future reports, obviously, we'll start seeing a trend and see how that's looking moving forward and have a more grander discussion on what those numbers are looking like. And then, so for charity care, and the next few slides are set up similar to this one. So what we saw, as I mentioned earlier, is a change from the previous trends, 2016 to 18. You'll see here bad debts. 1.7% annually was the increase we were seeing during those years. From 18 to 19, we saw a significant increase on that, up to 13.5%. On the previous slide, we had charity care, which was increasing around 10% annually. It went up 40% from 18 to 19. So something going on there where, as we talked about, we saw Medicaid expansion, the expectation of bad debt charity care going down. From 18 to 19, that's not necessarily the case. So that's obviously something we're going to keep an eye on moving forward. And then undercompensated care. So this is Medicare and Medicaid payments compared to cost. Obviously, Medicare and Medicaid do not pay cost. So this is showing what those undercompensated care numbers look like. So again, 16 to 18, Medicare was increasing about 12.5%, and Medicaid 5.7% annually. Kind of pretty static in Medicare. Obviously, that there's not a lot of payment changes there historically, but a little increase, but a doubling of the Medicaid undercompensated care. So as you'll see, between Medicare and Medicaid in 2019, about $2.7 billion of payments are undercompensated care, $2.7 billion less than the amount of cost that a hospital is seeing. So as I mentioned, similar to the previous report, stakeholder meetings are parallel to those meetings, trying to just make sure everyone's reporting consistently, making sure we've got the best reports and public information out there for our legislators to act on, right? So something, if you're interested in participating, please feel free to reach out to me and I can get you connected to participate on those work groups that they're currently setting up. Jessica, if you go to the next slide, please. So the Chase Annual Report, we talked a little bit about the fees and payments related to the Chase. This is a report that's produced annually due to the legislature every January 15th. Now, like I said on the last few slides, we're looking at the previous 3 years of trends and then to an 18-19 trend. So what we saw, total payments from 16 to 18 going up about 8% annually. That's cut in half from 18 to 19. So a reduction in total payments to hospitals. Same thing with costs, 7.8% to 5.9%. So a bending of that curve maybe. Obviously 1 year does not make a trend, but with 20 coming, I wouldn't anticipate to see some large increases there, right? I think we all can agree there. But what does it look like moving forward? When do we get back to where we were, or what is our new level? Where are we going to be? I think that's something that we're all interested in. But even prior to COVID, we started to see a bend in some of those trends. Next slide, please, Jessica. Same thing with margins. Now, this is where we start seeing some things going the other way. Total margins, we were seeing 10% increases in total margins annually. It's huge number. Particularly 17 to 18 was a big year for hospitals. Obviously, we're pulling these from some cost reports and submitted data. So there's a lot happening there, but that same data being submitted from 18 to 19, we saw a 16.3% decrease in total margins. I promise you, when we're talking about public option and hospital profits, that's not something that's going to be mentioned up front, but that's a big decrease. Same with adjusted discharges. We're seeing going from 3% increases to 0.3% decrease. Again, 0.3% decrease prior to COVID. We all know 2020, we saw a big dip, 10% maybe decrease in discharges. So seeing that bend before. So what it looks like moving forward will be important. And I just have a couple other ones I'm going to read off here that we kind of, it's also broken down on the Chase report on a per patient basis. So obviously payments and margins, costs, really dependent on utilization. So the report also breaks it down by per patient basis. So on a per patient basis, hospital payments decreased 4.4% from 18 to 19. Hospital cost per patient decreased 2.7%, and hospital margins decreased 23.1%. So as I said, 1 year doesn't make a trend, but we were starting to see that trend change a little bit, or that data point, I should say, that data point changed a little bit before COVID. Next slide, please, Jessica. And then the last thing I just wanted to talk about, and for those of you in the finance departments at a hospital, you're probably well aware, the state is looking at making inpatient base rate changes. Now, they are modeling this similar to how the public option is being modeled, with creating a standard rate and then adding on for certain demographics or financial standings. So originally they were going to try to implement this in July of this year, after presenting it in September of last year. So they were trying to do it in 6-8 months. After some feedback from CHA, from hospitals, they did decide to delay that to July 2022. So right now there are discussions ongoing with the state, with hospitals. They have a bi-monthly stakeholder meeting. The next one is upcoming on May 6th and 7th. The numbers will be impactful. Obviously, it is not new money that's coming in. It's going to be the same amount of money redistributed between the hospitals. Now, previously, hospitals' base rates for Medicaid were based off of Medicare base rates. So, some of the add-ons that hospitals were seeing in those Medicare base rates, Medicaid is not including in their proposal. So from a proposed standpoint, where we stand, CHA has significant concerns on the impact that this change will have. We are working with the state. We're meeting with them monthly, having discussions in the methodology, but obviously in a bigger picture, is this the right time? Is this the right methodology change for the state to be making? I think that's a discussion that we'll be having with them as well. But really in the operational side, digging into what makes sense when we're looking at a Medicaid specific base rate and working with the state. If you're interested, these are posted online, these stakeholder meetings with a link. If you can't find them, please feel free to reach out to me. I can forward you that information. So with that, I think that concludes my section and our presentation. So I think we'll open it up to questions from anyone on what Tom or I discussed this afternoon.
As people are teeing those up, maybe I'll just take a minute to comment on one thing. Ryan talked through a lot of the past legislation that has been passed, right? And a lot of that has been around transparency, overall financial transparency of hospitals, community benefit spend transparency around hospitals. We all know that one of this year, right? The fee schedules were put out there, and transparency, all with the goal of trying to, foster competition, I think, across the industry. Reasonable goals, how you get there, sometimes a little tricky administratively, but reasonable goals. I think when you try to put that through the lens then of a public option, which one could argue that maybe the state and the legislators have decided that competition isn't working, which I don't think, the actual results indicate that, but that's what they believe. You get a public option proposal that says, we, the government, have decided how we are going to make things work in the individual and small group market in this state. And this is how things are going to get paid for. And, it comes down to really just like a tax. It's a tax on those who have large group coverage to help pay for small, and those who have small and individual coverage. And I think it has the potential to really disrupt the market. Maybe it's a good thing. I personally don't believe so. And to think that one state can master this on their own, without this being done kind of nationally, seems incredibly ambitious to me, with a ton of unintended consequences. I'm fascinated by this journey of Colorado going down the public option, and we've got ourselves to this point as a state, and we are all going to see how this plays out.